We are live now, doctor.
All right. So, good evening, everyone. I, Dr. Preeti Kamdar, Secretary of the Maharashtra Ophthalmic Society, welcome all of you to this series, the next in our line, that is MIGS Decoded. The speciality of this series is that each speaker is given 30 to 40 minutes to address the topic in detail. And today we have none other than Dr. Tanuj Dada, who is just the right person in India to tell us about MIGS. But before that, let me invite Dr. Anaga Heru, who is the president of Maharashtra Ophthalmological Society, to address us. Dr. Anaga, over to you,
Yeah,
please.
thank you so much. And very warm welcome to one and all. We welcome our esteemed speaker, Dr. Tanuj Dada sir, and all the expert panelists here. Truly, this is a very special session because this is a special procedure, and I'm sure all of us are waiting and looking forward to hear you, sir. In fact, through MOS, we have been doing one procedure per month, webinars like this, which are specialized and focused on only one procedure. So we can give a lot of attention to detail, and we also send out Google Forms to all our members to find out what exactly questions they have in mind so that we can address all their queries. So looking forward to a great session, and thank you so much for being here.
Thank you.
Yeah,
Thank
thank
you, Anaga. And of course, Dr. Tanuj Dada needs no introduction. He is the head of the glaucoma services at All India Institutes of Medical Science and RP Center. And he's done phenomenal research. You name it, and he's done it. So that's why there's no one, as I said earlier, no one better to tell us about all the details of our MIGS than Dr. Tanuj. Welcome, Dr. Tanuj. And we are looking forward to listening to you. And we also have very good panelists, a very esteemed glaucoma specialist from all over Maharashtra, Dr. Kanchan, who is a glaucoma specialist from Latur. Of course, Dr. Mandar Paranjpe and Dr. Vidya Chelarkar, very experienced glaucoma specialist from Pune. Dr. Ketki Purecha, who is again a glaucoma specialist like me from Bombay, and Pooja Bhomaj, who's again a very experienced glaucoma specialist from Miraj. So without any further ado, let me invite Dr. Tanuj Dada for his talk. But before that, Manjula, can you play the uh, that 1 minute clip from Ajanta Farm?
Sure, doctor.
Yeah. Is it all right? Okay. So, Dr. Tanuj, please go ahead with your talk.
So I just want to check, can you see my slides?
Yes, yes,
Yes, sir.
we can.
Okay. So thank you very much to all members of the Maharashtra Ophthalmic Society and especially Dr. Preeti for this kind invitation. So today's talk will be on minimally invasive glaucoma surgery and whatever I understand about its truths and myths. So I have no financial disclosure. So minimally invasive glaucoma surgery is also called as micro-invasive glaucoma surgery. So this is a ab interno surgery where there is a self-sealing incision. It is a minimally traumatic surgery, and why it is gaining popularity is because it has got a high safety profile and a rapid recovery as compared to the conventional glaucoma surgery that we are used to, that is a glaucoma filtering surgery. So earlier, for all forms of glaucoma, you may have early glaucoma, moderate or advanced. Patient has high IOP but no optic nerve damage. So we used to do trabeculectomy for all these conditions. But over time, there was a realization that because trabeculectomy is a high risk procedure with there can be sight-threatening complications. So in patients who have got early glaucoma or just high pressure, there is a need for a minimally invasive surgery that can lower IOP but not have the complications associated with trabeculectomy. So that is how the minimally invasive glaucoma surgery came up to fill the gap for patients who are not controlled medically but do not need trabeculectomy because the glaucoma is not very advanced. So that is what we mean by minimally invasive glaucoma surgery. That is basically a surgery on the trabecular meshwork through ab interno route. Now, there's another term which you need to know that is coming up that is called combination MIGS. That means you combine two MIGS procedures. So it can be like dilatation of the canal along with stenting, or you can do surgery on the trabecular meshwork combined with the endoscopic cyclophotocoagulation. So you do combination of two MIGS. Dilating and stenting is the most physiological MIGS. And the other kind of combinations is you have a combination of medical as well as surgical therapy. So you have the iDose TR, that is eye stent, which has a sustained release Triverton. So in addition to your surgical ab interno stenting, you are releasing the medical therapy. And then you have very interesting technology called spyglass. So this is a IOL, and in the optic haptic junction, you have bimetopros sustained release implants. So that is another advancement that is going to come up. And the advantage of this is that, of course, you have the surgical efficacy, but with sustained release of medications, you are not worried about patient compliance. And there is a sustained release of drug which may be active for 2-3 years. So patient doesn't need to take eye drops, and it is good for the ocular surface. So MIGS, minimally invasive glaucoma surgery, has 5 minimum qualities. 4 are very good: minimally invasive, minimum surgical time, minimal complications, and minimal post-operative visits. So that is why it's very easy to do, and very short follow-up is required in terms of medication. The negative part of MIGS is that it's also called as MEGS. MEGS means minimally effective glaucoma surgery. So it is also minimally effective. So that is the negative part, and you must understand that why it is minimally effective. What is the principle that why this surgery is not able to lower IOP as good as trabeculectomy? So in the initial part of the lecture, I just want to make it clear that MIGS is not a good option for long-term control of IOP in any patient who has got moderate to advanced glaucoma. So trabeculectomy remains the gold standard. And second thing is, all MIGS procedure have a short lifetime. They may survive for 2, 3, 5 years. After that, they will fail. And then for subsequent IOP management, you will require a trabeculectomy with mitomycin C because glaucoma is a lifelong disease. So why is the reason that MIGS is not effective? There are 3 reasons. The first one is related to the outflow resistance beyond the trabecular meshwork. The second one is related to the fibrosis occurring in the trabecular meshwork. And the third one is related to the anatomy of the aqueous outflow pathway. So I'll just explain all the 3 reasons. So this is very interesting study done on the outflow resistance in enucleated human eyes. So they took off the entire trabecular meshwork. So if you took out 360 degree of the trabecular meshwork, how much was the resistance to aqueous outflow eliminated? So it was 49%. That means if you take away the entire trabecular meshwork, 50% of the resistance to aqueous outflow still remains in the eye. And that is because although there is a resistance in the trabecular meshwork, a majority of the resistance is also there in the outflow pathways in the sclera that is beyond the canal of Schlemm. So if you just operate on the trabecular meshwork like we do in MIGS, you are not going to eliminate the 50% of the resistance. So the IOP lowering efficacy of trabecular MIGS is very limited due to the unique physiology of the eye and the outflow resistance beyond the canal of Schlemm. That is the first principle to remember. Second, very important principle, all of us do trabeculectomy. Now, supposing I do very nice trabeculectomy, after 3 months, 6 months, it is going to fail. Why it is going to fail? Due to fibrosis. And for that, we all use mitomycin C. Now, in MIGS, when you're operating on the trabecular meshwork, there is no antifibrotic agent that you use. And that is the paradox of any glaucoma surgery. So you are trying to cut or put stent in the trabecular meshwork. So you are very happily to see that you are cutting the TM and the canal is getting exposed. But as soon as you injure the trabecular meshwork, there is a immediate trabecular wound healing, and that is proportionate to the amount of bleeding, because like blood is like a fibrinous tissue. So the moment you leave an open wound in the eye, the human body is going to heal that, and that is going to fibrose. And there is no drug to prevent trabecular fibrosis as of today. So in the natural physiology, there is going to be your incisions in the trabecular meshwork are going to heal, and there is going to be a rebound increase in intraocular pressure with MIGS failure. And this is especially important in the early part of disease where trabecular meshwork is still functional. So once you injure it, it is going to heal, and you may get an IOP which is much more than what was there previously in the disease. And those who are interested can read this editorial, Trabecular Wound Healing, the nemesis of trabecular MIGS. So this, nobody is talking about this. This is very important part of why MIGS is not successful in the long term. So this was one of the studies. You can see the title, Turn Back Elevation of the Intraocular Pressure. So IOP is very well controlled after you have done your surgery with the KDP or with a micro hook, but you can see what happens over time. The success graphs keep on following. So they keep on decreasing over time. And after 2 years, there may be a rebound increase in IOP. So this is directly related to the fibrosis occurring in the canal. So if you follow up this patient over time, there is a zippering effect. So you have opened the canal, but gradually it closes and your IOP keeps on rising and the success keeps on following. So a lot of studies are reporting 1 year, 2 year results. Very good you will get. But after 2, 3 years, you will get fibrosis and rebound increase in intraocular pressure. And this occurs due to several reasons. So primarily there is a fibrosis of the canal. And this is triggered by the injury to the outer wall. So these are very delicate tissue. When you cut with a KDB or a hook or a 26 gauge needle, you see in the video that you are cutting the TM, but you are also injuring the outer wall of the canal. The moment you injure the outer wall of the canal or the scleral tissue, it is rebound to have an effect on the wound healing. So there is a massive wound healing and your incisions are going to close to aqueous outflow. In addition, you may have fusion of the remnant trabecular leaflets. You have massive release of pigment that will block the outflow channels. Over time, there may be a membrane covering the canal, and you are also damaging the outflow channel. So the trabecular meshwork has got inlet and outlet valves. So those may be damaged by surgeries. So that is why over time, your MIGS is going to fail. The third important reason is that we have been doing studies on aqueous angiography. So how does the aqueous actually flow out of the eye? And if you see these aqueous angiography pictures, there are some areas where there is heavy concentration of aqueous outflow pathways and some areas where there is hardly any aqueous outflow pathway. So this is like a typical glaucoma case. You can see in these two areas, there is a concentration of aqueous outflow pathways. There is no pathway here, no pathway here. So supposing you put an eye stent in the area where there is no aqueous drainage pathway, although you can put it correctly, but if you operate on this area, there is no outflow channel in this area. So it is not going to drain. So there is a peculiar anatomy. It is not that you have 360-degree flow of aqueous. It is concentrated on certain areas. If you hit that area, you will be successful. If you don't hit that area, you won't be successful. And this technique is not readily available because it's a very expensive OCT machine to do aqueous angiography. So that is the reason why many of the stents may not actually be functioning, although they're anatomically well placed, because they're not in proximity to a collector channel. So these are the three principles why MIGS is not very successful in lowering intraocular pressure over the long term. Now, you all know in all talks of glaucoma, there is the issue of target IOP. So for any patient of glaucoma, whatever stage, IOP always has to be below 18. And in a simplified nomogram, we say early glaucoma, moderate glaucoma, advanced glaucoma, IOP should be less than 18, less than 15, less than 12. So these are the cutoffs. Any glaucoma patient, at least whatever therapy you give, who has got a visual field defect or should be less than 18. So just keep this figure in mind as my talk progresses, that whatever is your intervention, IOP should go below 18 for it to be successful for a glaucoma patient, and very good if it goes 15 or 12. Now, the first principle that everybody needs to know before doing MIGS is gonioscopy, and that is something which is not normally done even in the OPD, but you can get away in the OPD, but in the operating table without a gonioscope, it's not possible. So whoever is listening to the talk, you please buy one intraoperative gonioscope, and every cataract case, you tilt the microscope and the head of the patient and just see what is happening in the canal. So this patient is, of course, primary congenital glaucoma. There is an anterior insertion of the iris. It's the prominent iris processes. And we view this angle, and then you make a incision just anterior to the eye. That is called goniotomy. And now you can also do the GAT procedure. So first principle, if you want to do MIGS in any routine case in the OT, you start doing gonioscopy and view the angle, because that is very important, and I'll come to it why it is important. Now, one very interesting thing that I was doing one case in the OT, and then so this was a GAT surgery planned for POAG. So I am very nicely operating under the gonioscope. I have created an incision in the trabecular meshwork. And then my colleague in the side table, there was a break and the colleague took the gonioscope. So I was left without gonioscope. So now you can see very carefully. Now I'm going to operate GAT without the gonioscope. So this is called water gonioscopy. You just tilt and there is a fluid here. So with that fluid, you can see the angle. So here we are doing surgery without any gonioscope. This is called water gonioscopy. You can try it. Don't do surgery, but just try to see the angle. You tilt the patient, put some BSS or saline, and you will be able to see the angle structure with, and your assistant has to keep on putting the saline. And when you tilt, there is automatically a crater created and the saline stays there. You can also put some viscoelastic. So here you can see we could do the GAT procedure. That was a compulsion, but I was very happy that without gonioscope, I could do the procedure. So just see again, this is without a gonioscope. You can see the angle and you can see the suture going into the canal of Schlemm, and it will come back from the other side. So this is view of the angle without the need for gonioscope. So tomorrow in the OT, you can all try this and you can see how the angle looks like. Now it's very important. You can see now the suture has come and I'll pull the suture and the GAT will be completed. Okay. So you don't need gonioscope over time. If you can do this, very good. But at least you start, even if you don't have gonioscope, start viewing the angle with this technique of water gonioscopy. Now, so you have understood what is MIGS, why it is not very successful due to physiological reasons. The most important thing is to view the angle and learn to see the structures of the angle and identify the canal of Schlemm. Now, the next section is what are different types of MIGS. And now there's so many techniques, so they are broadly classified into two categories. One is like trabeculectomy. You have ab externo filtration and the most famous implant is now pressure flow. So all the innovations which are successful have been taken over by big pharma or surgical companies, and then they are being marketed. So pressure flow is now very popular in Europe. So it is number of centers it has replaced trabeculectomy. Though it is wrong, I'll explain, but it is the most important implant for subconjunctival filtration. And the actual MIGS is the ab interno MIGS. So there are four categories. One is you enhance trabecular outflow. So you cut the TM or you disrupt the TM. It can be trabectome, GAD, bang, KDB, or you put stents like the eye stent or the hydrus. The second technique is to enhance suprachoroidal flow. So by creating a cyclodialysis cleft, so this can be done by initially what was CyPass and now it is mini-ject. So these are suprachoroidal implants to enhance suprachoroidal flow. The third category is ab interno filtration. So this is the Zen implant and some minimally invasive microsclerostomy. So here the implants are put from the anterior chamber and out through the sclera into the subconjunctival space. So this is the Zen implant. Now it has lost popularity because of pressure flow and the results were not very good. It has still not come to India. There was talk 5 years, since 5 years to bring this to India. And finally, you have also a category that is not actually MIGS, but it is still classified under MIGS. That is to decrease the inflow. This is endoscopic cyclophotocoagulation. This has got specific uses, and I'll explain later. So these are the different types of MIGS: enhancing trabecular outflow, enhancing suprachoroidal flow, subconjunctival filtration like TRAP, ab interno or ab externo, and finally the endoscopic cyclophotocoagulation. So this pressure flow implant, I'm just showing the concept why it is supposed to be replacing trabeculectomy. There is this 8.5 millimeter tube with a 70 micron lumen. So this is called the pressure flow. And with the Zen, it's a porcine collagen. So these are small tubular implants. So you just make an incision, put it in the AC, no need for iridectomy. And then slowly the implant will drain posteriorly. So the basic principle is that short procedure, no iridectomy, and there is a posterior flow. So you want to make a posterior bleb. So the concept is very good and it is picking up. This has become very popular. Again, I'm telling in Europe. But the problem is that as compared to trabeculectomy, it has much less success rate. So it is not comparable at present to trabeculectomy. All studies have shown the IOP lowering efficacy is less. And because of that, it has not got the clearance from the FDA. So in USA, this pressure flow is not available. And again, I'm telling that you have a small lumen and the problem of fibrosis is there. So it is going to fail over time. So this has still not come to India, and the Zen is the ab interno. Now the problem is that you are injecting mitomycin C over a small area where the tube will come out, and when you inject localized mitomycin C, that is like a time bomb. So you can get all the complications of mitomycin C, including phlebitis. And the main problem with Zen implant was again there was very high chance of fibrosis and bleb needling. So very high chance of failure. So both the Zen and pressure flow have failed against trabeculectomy, which has far exceeded the IOP lowering efficacy of both these procedures. Now coming to what is the most popular technique among all anterior segment surgeons, and now trabecular MIGS is more being done by the cataract surgeon as compared to the glaucoma surgeon. So you have four categories. One is trabecular stenting. The second one is trabecular cutting or trabecular disruption. Third is trabecular dilating. And the fourth one is a combination that you dilate and then you cut the TM. So there is something very exciting coming up in MIGS, and it is like having a flight without the need of a pilot. And for all those who are not very good surgeons or who have left, who have not started MIGS, so this is like doing surgery without the need for surgical expertise. So why I have put this Air India flight? Because the name of the procedure is called flight. So this is very exciting advanced in MIGS. This is called femtosecond laser image guided high precision trabeculotomy. So this is not done in the, you don't require a sterile environment. You are not opening the eye. So this is a proprietary software. You dock this machine, and on the screen, this very nice OCT guided image with the gonioscopic guidance of the trabecular meshwork comes, and then you press a switch and it will make a 500 micron width crater in the trabecular meshwork, 200 micron in depth. And because it's a femtosecond laser, the surrounding tissue is not damaged and there is very less tissue response. So you have this cleft which is created patent up to 2 years in the current studies. So here you are not using any surgical expertise. So any of your OT staff or anybody can be trained. You just dock this machine. On the screen you get the TM and it will focus and you just press and it will cut off 500 micron. So this is a very exciting advance, the flight, the femtolaser image guided trabeculotomy. And another advance is you may have heard of the interstellar missions of NASA. This is the Voyager spacecraft, which has now crossed the solar system beyond Pluto, and it is very fascinating advance from NASA. So although it is not a MIGS, but this is also a very recent advance, which is definitely going to make a dent in ophthalmic practice. And this is the Voyager system. So this is a non-contact SLT laser, which was invented by Dr. Belkin from Israel. And because it's a very promising technology, now it has been taken over by Alcon and renamed as Voyager. So when you do SLT, you have to make the patient sit on the slit lamp, you put in a gonioscope and then you fire one shot. Here, the laser is being delivered through the sclera. So the patient just sits like on the NCT machine and there's a default laser energy and it will automatically focus and deliver 120 spots over 360 degree. So in 2 to 3 minutes, your entire surgery of the SLT is over and there is no need for the surgeon to put in a gonioscope and focus. So this is another very advanced development in the field of delivery of lasers, and it is going to impact because it doesn't require trained manpower. It can be done in the rural setting or anywhere where trained ophthalmology is not visible, and the side effects are not like very less. So this is also something which is now going to come up as a non-invasive way of lowering intraocular pressure. Now, there are many ways to cut the TM, but there are two new technologies. One is this is from J&J Bausch and Lomb, the Helios excimer laser. So this will be coupled with the phaco machine. So you have this probe which goes and punches 10 micro holes of 210 micron diameter. So this again, you are bypassing the TM. And there is a semi-automated trephination system. It is called MINT, minimally invasive nasal trabeculostomy. So again, these are going ab interno and making small holes in the TM to bypass the obstruction at the level of the trabecular meshwork and make aqueous flow into the canal of Schlemm. So these are very precision instruments to make small holes in the trabecular meshwork, which is a type of trabecular cutting procedure. Now, the second type of procedure is what I call viscodilatation of the canal. So first one is called ABIC, ab internal canaloplasty. Here you're putting a limited probe and you are injecting just viscoelastic to dilate. So it is trying to restore the physiological function. And then you have two new technologies from the ones New World Medical, which are making the MS glaucoma valve. So this is called the VR360. So here you are injecting 360 viscoelastic in the eye in one go. And then you also have the option of cutting the entire 360 TM. So you are injecting viscoelastic and then you also have the option to a 360-degree trabeculotomy. And this is a new system which is called the streamline system. So here you are making punctures, 150 micron punctures in the canal, and on both sides you are dilating the canal with viscoelastic. So this is a streamlined technology where you're punching holes and injecting viscoelastic on either side. And this is the 360-degree cannulation with viscoelastic insection and followed by trabeculotomy. So what we are doing with the suture, that is GAD, these are specific instrument designed to inject 360-degree viscoelastic and then also cut the canal. So this is the VIA 360 system, and previously you had the Omni system. This was 180-degree on both sides. Now this is catering to entire 360 circumference in one go. And then the streamline system, which is making 150 micron goniotomy, and with each goniotomy, it is injecting viscoelastic to dilate the canal on either side. So this is the second technique, viscodilate and then cut the canal. Now the third passage that is being used is suprachoroidal drainage. So here you are trying to insert implant between the sclera and the ciliary body. So you are making a cyclodialysis cleft to enhance the suprachoroidal outflow. So there are two current implants. One is the mini jack. This is a silicone spacer. So these are basically uroskeletal spacers to enhance supraciliary flow. And the new one has come. This is the scleral allograft. So this is called AlloFlow UVO. So you have first time use of a biospacer where they're using a scleral graft to create the cyclodialysis. And I just want to highlight that the use of, although this has been highlighted as the first use of biospacer in glaucoma surgery, this was our publication in 2022, where we have tried to augment trabeculectomy with a scleral graft from the patient's own sclera and then made it a round structure and used it as a spacer for a cyclodialysis cleft. So this was the use of a sclera for a cyclodialysis cleft in a patient of trabeculectomy to enhance long-term success of trabeculectomy. So it functions both as draining the aqueous as well as from the suprachoroidal space. Now, this is a very new advance, which is a totally different mode of action. This is called cilioscleral interpositioning device. So here the difference is that this is not connected to the anterior chamber. So you are making incision in the inferior part of the limbus and then interpositioning this device, which is an acrylic device between the sclera and the ciliary body. So this is supposed to enhance the suprachoroidal flow or the supraciliary flow. It is not connected to the anterior chamber. So there is no question of corneal endothelial loss or the creation of a bleb. So the superior area remains free from any surgery and you can use it for future trabeculectomy. So this is a new concept of cilioscleral interpositioning device where it is not connected to the anterior chamber, unlike the previous devices I showed you, which are creating a cyclodialysis. And finally, we have the endoscopic cyclophotocoagulation. So the disadvantage of this is very expensive machine. I think it is going to cost 75 lakhs. So no need to buy the machine, and the probe is costing 3 lakhs. But since we have an RP center, I'm just showing you a small video where we are using it. This is primarily being used for patients of angle closure glaucoma. So you have done the phaco, you have put in a posterior chamber IOL, then you put in an endoscopic probe, and this is an illuminated probe which delivers laser energy. So you have to focus on the monitor and then you will see the ciliary processes. So by directing the laser energy, you can ablate these ciliary processes one by one. So ideally more than 100, if you achieve 180-degree or 270, that is very good for IOP lowering. And this is especially helpful if you have patients of plateau iris syndrome or where you don't want to do a combination surgery. There is a small pupil, lot of inflammation. So there, as an interim procedure, you can do phaco ECP, and this was shared in the glaucoma GSI group. This recently published our results of phaco ECP as compared to phaco alone. So definitely it can lower IOP. And in patients who are not very advanced, you may get away with a target IOP without the need for a subsequent trabeculectomy. So now you have seen all the gamut of the MIGS procedure, suprachoroidal, trabecular MIGS, decreasing inflow. So now the problem is what is known as problem of plenty. So you have so many devices and technologies available. So supposing this patient comes to your OPD tomorrow, patient has got primary open angle glaucoma, cupping, visual field defect, and pressure is not controlled. So now you have options which are so many. You can do stent, hydrus, KDB, bang, micro hook, get SLT, or you can just add medicine. So that is the current dilemma. And that is why doctors like me, they are known as CMP. So Kanchan, are you hearing the talk? Dr. Kanchan?
Yes, sir. Yes, sir.
So what is the meaning of CMP? So anyway, that is just to humor you. So glaucoma specialists like me are confused mass of protoplasm. Okay. Because nobody knows what is to be done. Everybody's advocating. Somebody's advocating you do eye stent. Somebody's advocating you do hydrus. Somebody's advocating you do KDB. So nobody actually knows what is right. So everybody has this own say. That is why currently the glaucoma or the ophthalmic fraternity is utterly confused on what MIG is to use for which patient. Okay. So I am included in that CMP. So let us start with eye stent. Most popular MIGS. Everybody you can see talking about eye stent. Now you have four generation. You had eye stent 1, then you had eye stent inject, then you had eye stent W, and now you have eye stent infinite. So there are four generations. Most valuable item as compared to the price and the smallest implant in the human body. So it is supposed to be inserted and bypass the obstruction in the trabecular meshwork. So very nicely, videos look very nice. You are putting this small implant in the human eye. And so it has got this drainage hole. So you puncture the TM, put in the stents. So earlier two stents, now three stents, and it is supposed to lower IOP by bypassing the obstruction in the TM. Now just concentrate on this study. This is the compare trial. So they are comparing two eye stents versus hydrus implant for lowering intraocular pressure. So success criteria was IOP less than 18 at 1 year follow-up. So you can see with two eye stents, how many patients got target IOP less than 18? It is only 9% of patients. And with hydrus implant, how many got less than 18? It is 30%. So that means even for early glaucoma, you are not going to achieve target IOP with either eye stent or hydrus, and eye stent it is worse. And other thing is this is only 1 year result, and you see these curves are falling down because of fibrosis. So what is going to happen 2, 3, 4 years? You can see that if it at year one only 9% are going below 18, then what is going to be the impact on glaucoma patient? So hardly they are going to achieve target IOP. So that is why whatever maybe the hype on MIGS, trabeculectomy remains gold standard. You see less than 18 at 1 year, 9%, and you see with trabeculectomy, mitomycin C, nearly 10-year follow-up, 75% patients are going to achieve less than 18 as compared to 9% with eye stent. So there is no comparison of trabecular MIGS. It is not going to achieve target IOP even for early glaucoma. And if patient has actually glaucoma, moderate or advanced or progressing early glaucoma, you have to do trabeculectomy. There is no MIGS that is going to work over the long term. And all these are requiring long-term IOP control, 1 year, 2 year. There is no benefit. And interestingly, before iStent came to India, so I was uh, I was sent this paper for writing a commentary. And when I read the paper, I was quite shocked because 1 year outcome of iStent in the intervention group FACO plus 2 iStent, IOP lowering was 8.7%. And the group published in control group, IOP lowering is 15.2%. So I was quite shocked that what should I write? I mean, the intervention is worse than the control group. I think somebody's audio is on and I can see some background noise. You can check, you can put your audio off them, some siren I'm hearing. So anyway, so I knew this very senior author. So I called him and I said, I have to give a commentary on this article and it is very atrocious outcome what you are reporting. So what should I write? So he was very gracious. He said, listen, I have stopped using iStent long time back. It is not useful. You can write the truth. So anyway, I wrote that what you are trying to report, that phaco with iStent is worse than just phaco alone. So it is causing very less IOP lowering, 8.7% even combined with phaco. So then that is why I didn't start using the iStent at all. I have not used in my practice ever the iStent. The other problem is you are very happy to put it in the TM, but you are not sure where actually it is. So many of the stents are buried within the trabecular meshwork. They are not draining. So you can read this article analyzing the shortcomings of trabecular micro bypass stent, and you can see what are the problems that nobody tells you when you use the iStent. And then we try to do this. Now we have put the iStent and we are doing aqueous angiography. So two stents very nicely placed, but only one stent is draining. There is no drainage occurring from the second stent. Okay. So this is one stent, this is second stent. So in one stent, there is drainage. In the second stent, there is no drainage because there is no collector channel. So this is very important. So half the, if two stents you have put, one is not working, that means it is not going to have any effect on the IOP lowering. So that is an inherent problem with the eye stand. It may not be close to a collector channel and it will not be functionally patent. Anatomically, it looks very nice. Now this new implant has come to India, the Hydrus intracanaliculaar stent. So it is going to dilate the canal over 3 clock hours. So it looks very impressive. It is very easy to put. You puncture the TM and insert, and then you can put your video on Facebook and you are feeling very happy, very nice surgery you have done. So this implant is in the TM now. Okay. So very good. You have done very good surgery. But now spend 1 minute on this slide. So this is very nicely studied than the horizon trial. So this is comparing phaco hydrus versus phaco alone. And they have reported 5-year results of what is the IOP lowering efficacy of the hydrus implant as compared to phaco alone. So you can see the difference in IOP between phaco alone, phaco plus hydrus. How much is the difference? 0.4 millimeter difference in the IOP, 0.4 difference in the medication. So how much was the additional percentage reduction due to hydrus? 2.3% additional IOP lowering as compared to phaco alone. So just keep this figure in mind that you are spending lakhs of rupees and at 5 years you are getting 0.4 millimeter IOP difference as compared to phaco, which is 2.3%. Okay. So why would you use it? You have to understand. And although there are reports of better visual field, better diurnal, IOP, less progression, but you concentrate on what is the IOP reduction. It is hardly anything. This is the like standard deviation of your measurement only. Now, if you see what we have been taught in medical therapy, what is non-responder in medical therapy? If a drug is causing less than 10% IOP reduction from baseline, you will reject the drug. You will not use the drug. You will say this patient is non-responder. Don't use the drug. 10%, less than 10%. So both iStent and Hydrus, you see the actual IOP lowering, it is very less. So if it was medical therapy, you would say don't ever use it. Now the thing is that if the iStent and Hydrus are so ineffective, why everybody is using it? Why is so popular? Everywhere you go, you say Hydrus iStent, Hydrus iStent, every conference Hydrus iStent. So why is that? So the issue is that currently MIGS is $1.8 billion market, and the forecast is it is going to go to 4.2 billion. So now all your conferences are going to be sponsored by these big multinational companies. So neither any society nor any conference you are going to have anything adverse or being mentioned about these devices. So everybody will say they are all very good, but you have to read the literature and see for yourself how good they are. Okay. So MIGS, they have five minimal qualities, and one quality is maximum income. So that is why they are so popular. It is not due to IOP lowering efficacy that you are thinking. It is something else. And the studies being reported in literature, some of them are reporting very good results. So one doctor analyzed these RCTs on MIGS, and what they found very interesting, 90% had industry funding, 60% author were shareholders, 80% authors reported industry association, and in the authors, 60% were actually employees. So there is heavy bias in the publication of these devices. So you have to be very careful when you read literature, and it's better to ask colleagues who are not industry speakers how actually the device work. So when both this was released, I talked to a lot of my colleagues in USA and in Europe. So all of them said, you please keep on doing your bang and get there much better. But in conference, they will never speak, or in webinar, they will not speak. This is no good because heavy income is being generated by these devices, and neither our societies will take a call on the actual truth because the society and the conference is being funded by these companies. So take home message is that how effective is Tebexler MIGA? So this is the American Academy report, iStent Hydrus KDP. The reduction in IOP is in the category of your non-responder. They will reduce IOP by 4 to 9%. That is the take-home message at 2 years from the American Academy. And you can see at 5 years what happened. IOP reduction was 2.2%. And why MIGS is so successful? Because FDA gave approval, it has to be used along with cataract surgery. Now, the cataract surgery alone reduces IOP by 20 to 28%, at least up to 2 years. So that is why this is being added on to MIGS, and you are getting that MIGS is causing 30% IOP reduction, 20%, as good as TRAP. But that is not at all the picture. If you see American Academy report, trabecular MIGS reducing IOP 3.8 to 8.9% only. Rest is being caused by the cataract surgery. And how much medication reduction by MIGS? Only 0.4. And then also they're reporting that there is a bias of the industry, even with such small IOP. So keep that in mind. So now, if you take this American Academy report, and MIG is very poor, very unsuccessful, and you're not going to get target IOP. So there are two options. Either you modify the device or you modify the target. So now they said that 18, 15 is not a good target. So with MIGS, it should be 21 millimeter. So this target is actually not for glaucoma. I told you 18, 15 for glaucoma, but they have moved the target above so that you get better quality in the papers for MIGS success. So for India, like in RP center, so we have been using a lot of bangs. So 26 gauge needle under the gonioscope, you peel the TM. Okay. So 100% it will give you as good a result as the or better than Hydrus or iStent, and this is hardly any cost to the patient. And we modified this technique to visco bang. So actually, if you see the dimensions of trabecular meshwork, 26 gauge needle is too wide, it will damage adjacent tissue. So we use 30 gauge needle that approximates the diameter of the trabecular meshwork. So first we make a nick, we inject viscoelastic to dilate the canal and then cut the canal on both sides. So this is called visco bang. So with simple devices, you can innovate. You make an incision, you inject viscoelastic, and then you cut the canal. You can cut either side or both sides. So you will see now you can see this air bubble and the viscoelastic going inside, and then I'm going to incise. So this is very simple technique, visco bang. And this is our IGO publication. So again, this is giving IOP less than 15 with medication, but this is combined with cataract surgery. So that keep in mind. So it is giving as good or better than all your iStent or Hydrus, the IOP outcome. Now, last part of the talk is what is best for our country and best in IOP lowering efficacy, that is the GAD procedure. If you have any disease of glaucoma where the trabecular meshwork is faulty, pseudoexfoliation, pigment dispersion, serum-induced glaucoma, you have a high IOP and mild to moderate disease, you can go ahead and do the GAD procedure. So one procedure you must learn, it has got definitely better outcome than the bang procedure. So any patient who has got moderate to advanced glaucoma, do GAT. And procedure, just short video, you have to cannulate with 5-O-proline, make an incision on top of the pigmented TM, and then just insert the proline suture. It will come from the other side, and then you do 360-degree trabeculotomy. And in patients who are not advanced, you can just do 180-degree. You don't need to do 360-degree. So this has got the highest IOP lowering efficacy as compared to any other MIGS. You have to be careful in patients with advanced glaucoma. You may get non-responders because the outflow channels are blocked. And even though you are removing the TM, you can still get a steroid response. If you use post-operative steroids in these patients, you can get very high IOP. So be careful of using steroids. GAT will give you IOP in the high teens. So if patient requires low target IOP, still you have to do trabeculectomy. It will not suffice for advanced glaucoma. But steroid-induced glaucoma, pigment glaucoma, anything with a TM has a deposition, it works very well. So this is the 5-year outcome of the GAD published, and you can see 80% success IOP less than 18 and 15 at IOP less than 15, 53% success. This is with medication. So you can achieve a low target IOP over long term, which is unlike the procedures of iStent and Hydrus. The only major issue is when you cannulate, you must see the passage of the suture for at least 2-3 clock hours. Sometimes what happens, U is not clear, the suture keeps on going, it is cutting through the iris and going under the iris, and it will keep on going. So you measure the suture to the circumference and then gradually inject so that it is not going in a wrong place. And very important thing to remember, never dilate. So many of these procedures are being done with cataract surgery. Cataract surgery, we dilate the patient post-op or give tropicamide. So when you're doing GAD surgery or any MIGS, don't dilate post-op, because now you see we have done the GAD and you can see this cleft. So in these patients, if you dilate, you will get this synechia formation very fast because you have an open wound of the TM. So in these patients, you must give post-operative pilocarpine, and here you can see inadvertently one of the patients was dilated instead of pilocarpine, and the iris has gone in the cleft. So we had to go inside, and you can see I'm removing the fibrinous tissue and disengaging the iris from the cleft. So this happens if you dilate. So after GAT, you have to restrict the patient activity for 2 weeks, head and elevation. Again, I'm emphasizing use pilocarpine for at least 4 to 6 weeks and restrict patient from gym activity or Valsalva maneuver. So currently, I think it is the most preferred MIGS, hemi-GAT or GAT. You have to check for anticoagulation, always operate with the head end so that there is less chance of bleeding, and use a high viscosity viscoelastic. And post-operatively, patient should not have any Valsalva, coughing or constipation, and don't dilate, use pilocarpine. So which MIGS is best? This is a meta-analysis of the efficacy of MIGS. Phaco alone, followed by Phaco iStent, followed by Phaco KDB. So KDB microhook bang better than iStent Hydrus, and the best one is Phaco GAT. The only negative thing about Phaco GAT is that it has got the highest hyphema rate. So you have to warn the patient that there may be hyphema and decrease in best corrected visual acuity. So to summarize, if you have a patient with just high IOP, no glaucoma, who is very rich, you can do whatever you want, ice and hydrus. I am not doing. For early glaucoma, you do not need to remove the entire TM. You can use bang, micro hook, KDB or hemicat. Once patient reaches moderate glaucoma or any high pressure glaucoma where the TM is at fault, like pseudoexfoliation steroids, or even with failed trap, you can attempt a 360-degree GAT. And this is also now the primary procedure for primary congenital glaucoma and JOAG. But once patient reaches advanced glaucoma, you should only try to do tabectine with mitomycin C. You will achieve long-term IOP control. What about angle closure glaucoma? Here, the efficacy of MIGS is very less as compared to PUAG, and you need to learn one extra procedure that is called goniosynecholysis. So you have to lyse the synechia to expose the TM, and then you can do any MIGS procedure. I also told you about the endoscopic cyclophotocoagulation, especially for plateau iris or chronic ACG cases, you can do. So this is a difference for ACG. You need to do goniosynecholysis. And this is again aqueous angiography, angle closure, no flow. And once we did the goniosynovitis and bang, you can see the outflow of aqueous. So even for angle closure, MIGS can work if you do it after goniosynovitis, especially for early glaucoma. So in my opinion, for early glaucoma, you can do bang or any instrument for cutting the TM to 90, 120 degrees. But if you want to learn just one MIGS for all forms of glaucoma, that should be GAT with 5-O-proline. That is the most cost-effective procedure, much better in terms of IOP lowering efficacy as compared to any other expensive MIGS. So which MIGS is best? So there was very nice editorial that said beauty lies in the eye of the beholder, but the problem is that the beholder's eye is colored by this money. So there is a disparity between the quality of evidence and actually how people are using MIGS right, left, and center. And of course, this is very nice statement given by the father of our nation that the only tyrant I accept in this world is the still voice within me. So with so much options available for surgery and for making money, you have to see who benefits. Is the company benefiting, society benefiting, you are benefiting, or actually patient is benefiting or no? So this actually depends only on your conscience. What is your conscience? So you have to learn that it is all about ethics in MIGS, and I leave you with the definition of ethics. It is knowing the difference between what you have a right to do and what is right to do. Thank you very much. Jai Hind.
That was a master class, and it was a very honest, very critical lecture I have ever heard. And so many such clear views. And so let me go ahead with the questions which people have. Kanchan, can you ask the first question? We have that na, in our list.
Yes, ma'am. Actually, sir has covered many.
Yes, but let's just ask,
Let's, yeah, yeah.
first question if you can
First
ask.
question is, what are the risks of MIGS?
Yeah.
See, I'll tell you one major risk. So once you are cutting the TM, okay? So people are not doing gonioscopy before. So I was in the OT and my very good SR was, I was seeing her doing the bang quietly. So very, very confidently, she inserted the needle and went straight to the ciliary body. So she thought the ciliary body is a TM. So I was totally shocked that what is going on. So I told her कि बच्चे तुम क्या कर रहे हो? So I thought she's because I have been doing gonioscopy since years. So I know what is the TM, but I don't know how the trainee sees the TM. So on the table, they are hitting the wrong structure. Now, if you poke the 20 cm needle into a wrong structure, you can cause iridodialysis, you can cause cyclodialysis, decimate membrane tear, and intense bleeding. Okay. So first thing is you have to learn to see TM, and that is why I shifted to GAD because GAD there is a mild suture. You cannot hit anything ciliary body with the suture. Okay, so that is why it is a safety margin. It will only progress if it is in the canal. Whereas your needle is very sharp, your KDB is very sharp. It can go through any structure you want. So that is one thing, and major problem is bleeding. If you're not careful, many times in the OT, you start and you write patient is not head and elevated, and you leave the patient with low IOP. So there can be massive bleeding. So that is the problem. You have to tell the patient you may have to go to OT again and warn the patient to have head and elevated in the home also. That is the major problem with MIGS.
So then, so those are the two. So one is learn your gonioscopy well. before you even
Absolutely.
attempt it. And the
Yes.
second is, yes, hyphema. Dr. Mandar, do you stop any blood thinners the patient is on before you do MIGS?
Yes, I do.
Yes.
And there are two class of blood thinners. There is the ecosprin, and the second is the clopidogrel. If the patient is on ecosprin, generally 8 days, but clopidogrel is a difficult drug because even if you stop the drug, there is no guarantee or the chances of operative hyphema is still there. So I'll be a little wary of operating on patients who are on clopidogrel, especially long-term clopidogrel. And now there is one lesson which I learned recently is a patient said he's not on blood thinner. Unfortunately, patient was taking a statin, which also has blood thinners. And this the patient doesn't know. So please confirm, see the prescription of the physician and check the contents of the tablet to see whether the drug or the combination has a antiplatelet agent. But I just want to ask one question to sir. In case you have such a situation, how do you deal with it?
Now, see, the thing is that firstly, when you have done the surgery, you will start getting bleeding. So don't leave the active bead on the table. Either use AC maintainer or like the you have seen DSEC, DMAC, they put an air bubble and wait. So you put an air bubble and wait. There should be no active bleed on the table and keep the head end elevated. And give the patients, if you are scared of the IOP, give some diamox to the patient. Air bubble should be there. And second thing is you have to counsel the patient. It is not like you can, it is like the RD silicone oil surgery. No, they have to be propped up, no activity, no head down, no heavy weight for 2 weeks. Otherwise, definitely they can get rebleed. So you have to warn the patient, but it is not a major thing. We have had, I think, I have to go to the OT for 1 or 2 cases to evacuate the hyphema, but it is not a very major deal.
So, but you also do stop blood thinners.
Yeah, it is mandatory to
Right.
stop. We have to
Correct.
check with cardiology and also monitor
Yeah.
INR.
True. Correct.
Sir, I want one question I have.
Yes, ma'am.
Uh, so microhyphema, then later on also patients are seen. Like once they start anticoagulants, they again can get micro in between spikes of IOP also are seen in them. What to do about that?
So actually that is what Dr. Mandar was saying. Anticoagulate is the issue. And especially you have to be careful that if IOP is very low, so then you are done GAT and you are also giving medical therapy and IOP goes low. It can rebleed. So microhyphema is a issue. So you have to discuss case by case pros and cons with the patient and the INR and the cardiologist. So that risk will remain in any surgery, even for trabeculectomy, DDT, patients anticoagulant, they can bleed.
That is one issue. You want to ask the next question, Kanchan?
Yes, ma'am. So, next question is how long do the benefits last?
Yeah.
तो
Pooja,
पहला तो
you've
क्वेश्चन है
been
बेनिफिट
doing.
है कि नहीं, पहला तो यही क्वेश्चन है बेनिफिट है कि नहीं, वो आपको मैंने बता दिया.
वो तो बता दिया है, sir. So Pooja has been doing a lot of GAT, you know.
Yeah.
So Pooja, how long do you think the effect of GAT lasts in your hands whenever you've been?
So currently I am seeing like till 2 years at least all of them are doing well. But at the end of 2 years, few of them, say like 15-20% of them need one anti-glaucoma medications. That is the current thing. But I think I'd like to ask sir like how long he has seen GAT functioning and how long it has been effective in his hands.
So actually, patients who have got high IOP and no optic nerve damage, it will function very well, and it can function like you saw the study. It can function 2, 3, 5 years. Beyond that, I have no follow-up. So up to 5 years in literature, it is functioning. Okay. And
Okay.
if you want to be very cautious, you keep on doing annual gonioscopy. You will see how much of the angle is open, how much is zippering up.
Okay.
So
Right.
and if the IOP start rising, you have to escalate the medical therapy.
Yeah.
Right.
So
Yeah.
it is a tampon. It will definitely give a IOP lowering efficacy. IOP will keep on creeping over time as the fibrosis occur, but it is the most efficacious of the all the MIGS devices. So it is the one thing you must do.
Okay. Yeah. So
Okay.
it has the steepest learning curve, but it is the most effective. And I think one of the cheapest. It's
Yes,
like the 50 Prolene and of course the
Yeah.
gonioscope, and you have a tilted microscope.
yes.
So now, what are the instrumentation for MIGS? So Vidya, if somebody wants to start doing MIGS, what are the instrumentation that they should have?
So I think first
Yeah.
thing you do what I showed you, water gonioscopy. Next, tomorrow in the OT, you tilt the patient head, put water, and you will see the angle. You will be very happy.
Sir,
Okay.
you have doing water gonioscopy after years of experience.
No,
You
no.
people start doing.
So you just try. Sometimes you get very good view of the angle. The routine case, not glaucoma case.
Got it. Yes.
Okay. So I tell my resident here during cataract surgery, you put in a gonioscope and you just with the
Hmm.
viscoelastic cannula, you touch the TM so that you know
Right.
you are touching. So once they start touching the TM, then you are can
Hmm.
incise it. So
True.
I give them one small Shinsky hook so they can make small incision. So then this we have micro hook, 26 gauge, 30 gauge. So then KTB. So whatever you can start doing after you have touched the right structure.
Hmm. Right.
You,
Identified the trabecular
yeah.
mesh.
I think
Yeah.
And
with 30 gauge needle or 26 gauge needle with viscoelastic inside. So viscoelastic is very important because you see, once you cut, you will have bleed.
hmm.
So immediately you can, if you inject viscoelastic, your bleed gets tamponade right there.
What do you use, sir, for the viscoelastic?
Actually,
You
for
use Helon or a high molecular weight, or you use a regular viscoelastic? What do you use as a
so,
viscoelastic?
so after getting this bleeding issue, so now for GAT, Helon 5 or Helon GV
Sure.
for all
Okay.
cases.
Great.
And for the injection inside the TM, what I showed you, visco bag, it is plain Helon.
Okay. Fair.
Sir, and one
Plain
question is
Helon.
about when do you do the mix procedure? Is it before starting FECO or after you finish FECO?
Very, very good question. So I always try to do for open angle glaucoma before starting phaco.
Before.
Before
Okay.
phaco, that time you have the pristine view, and second is that your bleeding gets tamponaded during surgery. So now you have done the cataract. Now there is hypotenuse eye and your IOL is in place. So at that time when you do, there is higher risk of bleeding because pressure is low. And if bleeding occurs at that stage, it can trickle through zonules, go into vitreous. And third thing is that supposing case is hard or cataract is not amenable, you may get corneal edema and then your visualization may be poor. So in POAG, I always do before, but that is personal preference. For angle closure, no choice, you have to do after phaco.
Pooja, when do you do GAT? Because many times the concept is the cataract is more important, do it properly and then go in for GAT. What do you do, Pooja? Do you do
So, yeah, like I do it after the cataract. It is more comfortable for me because the AC deepens and some blood is there in the Schlemm's canal. Identification is slightly better. So I always do it after the cataract.
Actually, you
so,
should learn it to do before also because now many patients, I have clear lenses. So we are doing like for JOAG, PCG, pseudo exfoliation or pigmentary. We don't do cataract, we just do GAT.
all right.
And then
Okay.
you'd be careful that you don't hit the lens. You put
Right.
pilocarpine, you
Like,
constrict the pupil and then do. So you must
Okay.
learn to do in the phakic eye also.
fair
So,
enough. Point well
so
taken.
ma'am, one question to sir.
Yeah.
Like, are the results of only GAT without removing the cataract as good as phaco GAT?
No, no,
Because I
that
have done very few of them.
no. See, result will never be as good because I showed you IOP lowering efficacy of phaco is 20%.
Okay.
But I recently I'm telling you last week, like 1 month back only, our OT sister's husband came. So steroid use for last 3 months, 40 pressures both high, clear lenses, 6 vision. So I had to do bilateral after
GAT.
3 days, one bilateral GAT. So you have situations where the IOP is high, optic nerve is normal, clear lenses. So there you don't have the option of removing the lens. But because it's an early disease, you will get very good outcomes. In pristine eyes where outflow channels are not disrupted, short-term disease, you will get very good because outflow is very good. So there it is very successful even without phaco.
Sir,
So
are there
that's
any
a good point.
strategies that you use to prolong the effectiveness of any of these mixed procedures? Like you want to keep the collector channels as patent as possible. So, drugs like ROCK inhibitors, do they have any role in the
So
post-operative
actually,
regime?
that is very nice question. Actually, that is coming up now that you give Rho kinase inhibitors and you then do the MIGS surgery so that it facilitates outflow. So in glaucoma surgery, one thing I do, which is Kanchan will know, secret for prolonging surgery, that is to pray to God before starting the surgery. But it's not in your hands how the body is going to heal.
So, which steroid do you use post surgery?
Actually, when you're doing with cataract, it is routine cataract post-op regimen, but no dilating drops. You have to give pilocarpine. But some of the cases I have done, especially for juvenile glaucoma, or they have had very high steroid response. So then I taper steroid at 2 weeks and start non-steroidal anti-inflammatory drugs. So this is a issue because normally you feel that you have taken out the TM, so why should steroid act? But still you get very high IOP. That is due to the steroid receptors in the outflow channels.
Just one question. What are the outcomes of KDB versus BANG versus GAT? So you've said that GAT is better, but between KDB and BANG, what would you prefer?
See, if you
That is
can,
a question which has been asked.
yeah. See, the when you use the KDB instrument, definitely the cutting is more smoother. But
Hmm.
the technique I showed you that you use 30K needle, you first put viscoelastic. Why I'm again emphasizing because when you're cutting, you are also damaging outer wall. So that is going to cause fibrosis. So you puncture, you inject viscoelastic, and then you cut. So once you get the need, then no need for KDB. You can do with 30
Yes.
gauge, 26
Oh,
needle. You will get the similar result because it is a similar in action, and maybe with dilatation you can get better result, and also it will tamponade the bleed right away.
right. So that's a very useful tip, Dr. Tanuj. And one question to Dr. Ketki. When will you just not do an MIGS? What is
Um,
an absolute contraindication in your this thing practice for MIGs?
if the cornea is hazy, means you cannot see only the angle structure, then we cannot go ahead with this.
Correct.
And I do not do it in very complicated cases where there is PAS, like in neovascular glaucoma or something, then I do not go for that.
Right. And also advanced glaucoma, probably we will not do
Yes,
MIGS.
advanced glaucoma.
Not do, and that is very important to understand. 6 months back, I got 11th in class 11th JOAG patient came for second opinion. So already trap was done and trap had failed. And next day patient was to eye stent was to be done. So God's grace, patient landed in my OPD. So I was shocked that what is going on. Like trap has failed. Now you are planning for eye stent. So you have to be very careful, ethical that in advanced glaucoma, TM is at fault, but the outflow channels are all blocked. So it won't work. Secondly, if it works, target IOP will be 18. You require 12.
Right.
And thirdly, it will fail very fast. And then you do trap. So you have done supposing GAT or KDB. Now you have open wound. Now you do trap after 3 months. You will get very massive reflux bleeding because fibrosis has not occurred. So don't be in a hurry to do trap after MIGS. It can cause very bad bleeding.
All right. That's a good tip. And you want to ask the next question, Kanchan?
Yes, ma'am. Another question is, what is the post-operative regimen after bang? As sir told already, pilocarpine is very important.
Yes,
How
yes.
many days do you continue the pilocarpine?
Actually, I am giving now for 6 weeks.
6 weeks. Okay. Uh, but there can be some inflammation. So in the
100%,
case of
100%. See, the thing is that uh, you have to do the gonioscopy. I showed you, very happy. And then you see the post-op, even for congenital glaucoma, the entire iris is very nicely in that cleft.
Okay.
So inflammation is all you are giving NSAIDs, you are giving steroid, but if it goes, iris goes inside, then surgery
Very
over.
well. Correct. The next question, if you can ask.
Where can we learn to do
Yes.
MIGS?
Yeah,
So,
that
under
is a
Dr.
question
Hmm.
which so many people have asked.
So you can go to Professor Kanchan and Professor Kirti Kamdar. So every MIGS, you first do gonioscopy. It is not rocket science. You learn gonioscopy, that is mandatory. And I told you start touching a TM with the cannula or Hedon cannula or viscoelastic cannula. And then every conference there is a wet lab now on MIGS. And though I will not recommend you do surgery, but you go to every wet lab of hydrus and eye stent. You have very good eyes where you
Wet
can learn
lab.
how you can poke the TM 1,000 times. So you tell them that I want to learn, but don't do in your OT.
So, all right, use resources wherever available, right? And Vidya, you teach a lot of postgraduates. So, do you teach them how to do MIGS also, or first it would postgraduates and fellows also? So, how do you teach them? Do you teach them MIGS or you restrict them to trabeculectomy?
No, no, 101%. You have to make them self-sufficient for life. So I have my junior resident who is in second year.
Mm-hmm. Okay.
First go he did GAT.
Areva.
Okay. So because they're seeing every day, we are doing a lot of GAT.
Correct.
So I have to teach them three things. One is laser PI, one is trabeculectomy, and third is GAT. These three things I will teach them before they leave.
That's wonderful. So there'll be complete glaucoma surgeons when
Yeah,
they go out
yeah.
after they've done residency under Dr.
Early glaucoma they can do GAT, advanced glaucoma they can do TRAP, and angle closure they can do PI. So at least they will help the country.
That's a wonderful thought, Dr. Tanuj, that yes, it's not
I
only,
have for
yeah,
sir.
yeah, of course.
Right. Sir, how do we transition from KDB to GAT? Because GAT in general, I mean, there is a perception that it's a little difficult surgery. There can be blockage, the suture may not go forward. So, how do we overcome that fear and how do we convert or learn GAT
See,
for the postgraduates? For the
I tell you, GAT, no, there is one very good thing that if your suture in the right place, only then it will move forward.
yeah,
With KDB and all, you are doing, you can cut through any blockade. So once you have done KDB and all, you just put a cautery and little blunting of the suture, and just above the pigmented canal, you make an incision and just make some posterior movement so that you get a gap for the suture to go inside.
yeah.
So in front of your visualization, at least 1 or 2 clocks, the suture will go in. You will see it is going in the canal. Otherwise, it won't progress.
Mm.
So actually, if you are doing or seeing every day, like I never used to, I was very late transition into MIGS. Okay, I used to see Arvind people, Swati doing GAT, then I saw Devinder Grover. So I also used to think exactly like you, it is very difficult procedure. Then my junior started doing. So it was very insulting for me that how come these people are doing and I am saying it is difficult procedure. It is not difficult. You do it 1 or 2 times because the canal is there. No, it will only go in the right place in front of a canal. So it is very easy actually. It is not difficult. I'm telling you, junior residents are doing all here.
Right.
Okay,
So
sir.
I think
They're
first
getting
is you
exposed.
need
Arvind
to
are also you ask
get
Arvind.
used to the tilting of the
Yes.
head and the microscope. Get used to the view, like how Dr. Tanuj has said, that touch it with a every cataract patient, touch the trabecular meshwork. And then probably once you get used to handling, it becomes easier. That's what Dr. Tanuj has been saying. Uh, hello?
Just one
Was I audible or
Yeah.
hello? Hello?
Yes, Apriti, you're
Yeah, I can hear you, although your video has become still.
frozen.
Mm, I think.
We can hear you.
Yeah, we can hear it.
Are you able to hear me?
Yes.
Yes, ma'am. You're audible.
One more important question. One someone has asked, is there any role of MIGS in pediatric glaucoma? So, sir, I think you have told already 360-degree goniotomies.
Yeah, so we used to do initially
Uh,
when I trained every pediatric, we used to do
I think I have poor
trabeculotomy,
network.
trabeculotomy, mitomycin C. And then we shifted to ab externo. We used to have fiber optic. We used to do ab interno trabeculotomy and even with the microcatheter. But once you do start adult GAT, then in pediatric also you will.
Mm.
So that is the best surgery if cornea is clear, and ab interno GAT is currently the first surgery to do not do trab, MMC and all in a child's eye. And there is no question of doing any eye stand or all these in child's eye. So GAT is the one thing to be done, and it is 360-degree
Yeah.
trabeculotomy.
One more question is hydrous
Hello.
implant versus eye stent, pros, cons, cost, and long-term efficacy. I think that also sir
I
has
think,
covered in
yeah.
हाँ तो
lecture.
अभी अभी एक और आ गया जो अभी hydrous is better in IOP lowering efficacy than iStent inject and iStent W. बट अभी उन्होंने iStent infinite लॉन्च कर दिया है, 3 iStent हैं, तो उसका efficacy is nearly equivalent to hydrous. I told you what is the IOP outcome. Kanchan, you please reply. What is the 5-year IOP lowering efficacy of hydrous as compared to phaco alone?
I stand was 9%
4,
only.
No,
0.4,
no.
0.4,
0.4%.
हाँ,
0.4.
0.4.
0.4 millimeter mercury, 2.3%.
Yes, yes.
ये आप लोगों को ट्रेनर नहीं करना.
Correct, sir. I think everything is covered now, ma'am. Questions are no more questions are left unanswered. Sir has covered everything in his lecture. Mm,
Sir, which
Ritika,
gonio lens do you prefer?
यार
Because now you have the disposable ones as well as the reusable ones.
नहीं, डिस्पोजेबल वंस तो एक्चुअली वहां से मिलते हैं आई स्टेंट और हाइड्रस वालों से. तो अभी तो हमारा वी आर यूजिंग स्वान जैकब.
Okay. And how do you maintain those? Because those lenses are the surfaces can get spoiled pretty fast if
Actually
you're.
that is the issue. So actually for RP Center we had initially got मतलब 6-7 lenses, so you have to handle them with care. That is no doubt about that, and they get pigmented also. So that is one instrument you have to handle with care. And now you have gonioscopes which attach to the microscope, like hands-free, so you don't require assistant. And there are a lot of gonioscope now where you don't need to tilt the microscope. So
So
there
I
are
have
advances occurring, but they are very expensive. But you are all doing very well in practice, so you can buy.
So I bought one where I don't have to tilt the microscope,
Very good.
and it really makes life easier.
Yes, yes.
Okay.
But now with your hydrogonioscopy, it seems nothing is required.
Yeah, you'll be very happy because you can do without gonioscope. At least definitely GAT is difficult, but bang and all you can easily do.
Okay. So we used to remove the pooling of liquid. Now you'll tell the sister, pool liquid there. So we
And
can
when you can put little bit viscoelastic, it won't. It will give very good view. You just try tomorrow.
sure
Yes.
do that.
Yeah,
Yes.
next OT definitely will try.
Uh, before we end the session, can we just play the clip from Ajanta Pharma, please? Manjula?
I'll do it right now, madam.
Oh, yes. Thank you. So that was the very, they can't hear us, correct?
yes, no.
That was an amazing MIDS.
Very good. You are medical sponsor. If you had surgical sponsor, you would have tough time.
It's such an honest lecture today. Wow.
It was as clear as sunlight. So I mean,
Absolutely.
there was no ambiguity anywhere. And I think that is what we need from leaders like you, because otherwise the market forces are so strong.
Now we need to rethink whether to do and what to do, which procedure to do.
I think it was very clear.
Yeah, very clear.
Bang, KDB, I mean, Bang and GAT.
That is all we
Yeah,
have to
yeah.
learn.
Yeah.
We were confused. Should we be starting iStent or no? Are we missing something? Now we have a clear understanding. We don't have to try it.
All done?
Very nice.
Should I go ahead, madam?
It's over the.
No, I have to. Should I play?
Yes, please.
Yes, yes.
Over. So, before I take everyone's leave, it is my duty to thank everybody, and I take great pleasure in it. Dr. Tanuj Dada, it was an eye-opener and a wonderful lecture as ever. There was no ambiguity, um, clear-cut instructions, what is good, what is not, what works, what doesn't. So, and I thank Dr. Kanchan for being an excellent co-moderator. And
Thank
of
you,
course,
ma'am, for the opportunity.
our panelists, Dr. Ketki, Dr. Pooja,
Thank
Dr.
you.
Mandar, Dr. Vidya, for bringing so much more to this webinar. Of course, the Ajanta Pharma uh, for facilitating the whole thing. And of course, Numeratech for having such a seamless meeting. Dr. Anaga, I think, is not here. Otherwise, she would have joined me in thanking all of you. So till we meet again, we'll take this lesson. And I think MOS is blessed to have somebody like you teaching us. So thank you, Dr.
Very
Tada,
kind
once
of
Thank you,
again.
sir. Thank you so
Good
much.
night to
Thank you,
everybody.
sir. Thank you very
Thank
much.
you,
Bye.
MOS.
Bye. Good
Thank
night.
you.
Good night, all.
Good night to everybody.